Thank you all for very stimulating discussions and presentations. I will remind you to text or tweet or email any of the comments, and if anybody has any questions, feel free to come up to the microphone. This is an appropriate time. One of the first questions, which came a couple of times, is can we get Dr. Carmel's email address again? So Dr. Carmel, if you wouldn't mind providing your email address, that would be great.
Carmel, C-A-R-M-E-L, at UMDNJ, University of Medicine and Dentistry of New Jersey, .edu. And email me and I'll probably get it out to you this weekend.
So one of the first questions from a tweet here is specifically about the future of private practice physicians. I'll add in not currently part of a large physician organization or employed by a hospital. What is, in the environment with the Accountable Care Organization, what is the future of a private practice physician like that? And specifically, should a private practice general surgeon join the Pioneer ACO in its current form? Dr. Carmel.
Well, I was in strictly private practice in the city of New York for 27 years. That's a reasonably competitive marketplace. I loved it. I think any of us would have to say to you frankly that the day of the single independent practitioner is over. The AMA is fighting hard to make sure that all of our new practice modes allow the independent physician, the independent practice to participate. That's why we fought so hard to get these new rules on ACOs. But it is a declining effort. The whole talk about ACO has frightened the hell out of doctors. And it's driving them to seek employment by hospitals or systems. MGMA has data that say by the end of this year, 40% of all primary care and 24% of all specialists will be hospital employees. The hospitals will lose money. The whole effort of ACOs is to handle chronic disease in an ambulatory setting. So hospital admission rates will fall, hospital volumes will fall, hospital dollars will fall. And so that building over here with, 10 stories, layer of ORs, layer of x-ray suites, that's the loss leader. That's not really the hospital. The real business of the hospital is over here in the ambulatory care building, where the hospital is managing its employed physicians for fun and profit.
Dr. Britt.
I think it's a mistake to think that the success story is obviously physicians and surgeons going to hospitals. Don't get me wrong, there's some good hospital models, but at the end of the day, when you become a member of some hospital settings, they define quality different than some of the physicians. And at least in our practice, we've noticed that there's a ratcheting down of the salaries or the incomes of the physicians who have joined the hospitals. So I think we need to be cognizant that it's not monolithic. There are some hospital systems that you probably shouldn't join. But again, at the end of the day, even ACO aside, what's driving them is the fact they can't recruit, they can't pay for electronic medical record, all those things. So we need to obviously find a way to give our members, our colleagues, some alternatives to just standing in line to be a salaried employee of a hospital.
Frank, any comments?
Well, I agree with, excuse me, I agree with both of my colleagues and what they've said, but I think what we're looking at is a business model transformation. And right now the call is a capital call to fund the transformation. The individual entrepreneur physician does not have the capital to fund the transformation. The delivery system does. The primary source of that delivery system funding is the hospital. And as Peter was saying, that hospital is going to de-evolve in this transformation. What is going to come out at the other end of this is going to be a whole new delivery system model It's going to be a delivery system of care for a population, which will have in it an asset called a hospital. And hopefully, if we wire this right, it'll be led by physicians and patients and not by hospital boardrooms. That's the ultimate goal, but that is a 10-year transformation, and we're going to go through this cycle of who's leading who through this. For now, it's all about the capital plan, and it's all about where the hospitals are, but at the end of the day, it's got to be about where the patients are and who's connected to those patients, and that's the surgeon.
Any other questions, feel free to come to the microphone or to tweet or comment. Dr. Satava.
Thank you very much. And Dr. Carmel, Frank, and LD, thank you for the enlightenment. Trying to understand this complexity is enormous. There was one thing that I didn't see much emphasis on that. It goes back to the RAND report of 2008 that indicated administrative costs due to new regulations, well-intended though they may be, have taken a portion of the pie for paying for health care from 7% in administration to over 30% the cost of health care. I understand the importance of having rules, regulations, and guidelines, but right now, 40% of health care is paid for patient care, and we are now having 30% paid for administrative care. Healthcare costs for the patient is going down. Healthcare costs for administration is going up. I don't know what the answer is, and I agree with the intention, but what kind of business model can we develop that takes more and more from our patient care and adds more and more to administration, which I haven't seen the evidence that adding more rules and administration actually improves the care.
Dr. Carmel.
Well, you're absolutely right that increasing accountability is increasing administrative cost. There is no question. And the public wants to know that we're giving them value for money. The way to do that is to make administrative checks. We will be, as you heard Frank say, we will be increasingly tested. There will be increasing metrics that we will have to jump through, and that will increase administrative costs. There is no question. The question is, can those administrative costs increase value? If, in fact, jumping through all of these hurdles means that the product, the health care we deliver, is better, then there might be value to it. I have to tell you that, honestly, there's no one who has data that supports that. But there is no question that we will be increasingly called upon to justify our medical decisions and the expenditure of money.
Rick, thank you very much for that question. And I really think it's, again, it's part of the cost of this transformation. When we look at, to LD's point about HIT, when we look at transforming this to an electronic medical record, if all we do is convert paper to an electronic form of paper, we've done nothing to enrich and enhance the care. We've actually got to create an entire data stream that links things like the electronic medical record to the National Cancer Database, to the National Trauma Database, to the National Surgery Quality Improvement Database. The next step is to link all these new innovations and guidelines directly into clinical decision making. All of that is a cost, and those are all the efforts that are out there. Congress didn't just mandate, well, everyone has to have an EHR because EHRs create quality. They don't. The only thing that creates quality is the relationship between a physician and a patient. And now we're trying to just lay down the infrastructure. So then how do we operationalize that infrastructure so you as a physician are have the maximal opportunity to improve care? That's going to cost. The other thing that the Affordable Care Act has tried to do is to limit the administration premium dollar. Now, that still doesn't necessarily account for all the administrative costs, but what they're trying to say is that 85% of premium dollar should be spent at the clinical delivery side. Whether that's administrative side or actual point of care, that's debatable. But only 15% should be spent at the administrative insurance side, and that is a good thing.
Let me talk turkey. Is this mic on? Can you hear me? Let's talk about extravagance in the ministry. I think that's what my colleague, Dr. Satawa, was highlighting. We have a 5 or 6 hospital consortium in Hampton Roads where I live. 5 or 6 hospitals, not General Motors, 5 or 6 hospitals. The CEO or president, who's overhead in my opinion, he doesn't bring any money into the system, he's overhead. He makes $6.7 million a year for a nonprofit hospital consortium. That's the sort of extravagance we have to address. He's slated in another year or 2 to make over $10 million. Again, I go back, when I look at the financial components and itemized components, he's overhead. So we need to really talk about that. A lot of people like to point fingers at the physicians, but some of this administrative surplus is costing us too much.
Thank you. Dr. Barry Salke.
I very much enjoyed listening, and what really sort of saddens me is that we are here at a meeting that has, I think last count was like somewhere between 2,300, 2,500 attendees. And I'm looking at the audience, and I see maybe 150 people in this room. And of that 150 people, I'm just estimating that maybe about 30, 40% are my age. If you can exclude that side of the table, maybe your age. And not as many young people are in this audience for whom this discussion is going to really come to bear. So it's more of a comment, and it is a question. What are we doing wrong to not have the appropriate audience in this here listening to what is going on and what is going to affect them? How do you see us making sure that the effectors of the care that's going to be delivered to my children and my grandchildren have it done in a proper manner? Because it's not going to be me, a couple of years maybe finished, and it's not going to be you guys over there except from the policy point of view. So what can we do to make that a little bit better, or actually a lot better?
Dr. Lerner.
I'd like to, as the chairman of this committee, I'd like to address that question. The question that I'm hearing is we need to have, or the problem is we need to have the younger people in our groups actually get involved in this stuff and talk about it and go home with a message and idea of what to do. I've been involved with this committee that does this for some time for SAGES, and one of the big issues is basically a housekeeping issue, and that is the time of this session. I think this session is important enough so it should be moved into the middle of the week when we have a fuller house. I think that people would tend to come if it wasn't at the end of the day. A lot of people have already left town. Other people are getting ready to leave town, and there's always the last minute things that they try to do. And it's not compatible with the meeting of, to have that meeting on the day when this is such an important topic and will remain an important topic forever. So my suggestion and my idea would be to move it further along. The second thing that has occurred to me over the years is that no matter how hard you want people to work in this field, this is a very difficult field to try to engage. I used to say, and I still say, that following politics is like watching the shifting sands. One minute you're on firm footage, the next minute you're in the middle of a sand hole. So it requires a mindset which is different than our usual practicing mindset. It's hard to base things on facts when the facts are just interpretive facts, and even those that are solid facts, as were presented today, are open for interpretation once they get to Washington. And I think those are the two big problems.
Comments? Yes.
You have to change the attitude of your organization. In this past year, I've talked to organizations who care about this, and I've talked to organizations who don't care about this. When I talked at the American College of Radiology, there were 2,400 people in the room. When I talked at thoracic surgery, there were over 1,000 people in the room. The fact that this session is so little highlighted in the program book, the fact that there is no sign that says this session is important to the future of your profession, represents the thinking of the leadership of this society. It is, and I see the same things at the state. Yesterday, I talked at UCSD to about 80 medical students who were lured there principally by the pizza. A month ago, I talked at the Medical College of Wisconsin, and faculty and medical students did not fit into their largest auditorium, and there were people quite literally sitting in the aisles and lined up around the room. That represents a difference in the attitude of the leadership of the organization. Organizations that are truly worried about the future of the profession will highlight this. Neurosurgery at the Council of State Neurosurgical Societies had to move to the main ballroom when I spoke on healthcare reform there. The leadership of this society has to understand that this will affect all of your lives. This meeting is structured to tell people how to earn more money, how to do their operations better. It is not focused on the big picture. And until the society focuses on a larger scope, 100 people will come to this kind of meeting.
So
Comments?
I feel a little differently about this. Whether it's 20 or 100 or 1,000, we can have this discussion in many different forums, and it's always great to see people engaged in national policy. But what I really think we need to do is go back and look at our current educational framework within our specialty societies, within our local hospitals, within our medical schools, and look at what's missing and make the necessary changes there. And we will see an engagement change. We have in my own school, we have fantastic basic science and education and fantastic clinical science education. We have no improvement science education. So we've started an entire program that begins in the second year where we talk about looking at health services research on our local performance. How are we doing and how can we do it better? And what are the things we need to teach our nurses and doctors and allied health to work as a team to drive improvement in taking and operationalizing this basic science and this clinical science and elevating it to the highest level of value. When we start that learning network here at the specialty society level where we're looking at SAGES data, at SAGES outcomes, and we're now comparing our opportunities to improve, who's nailed this and how are they doing it? And taking not just this basic science we exchange and not just the clinical science we exchange at this meeting, but we also start talking about the improvement science and the value proposition, the room will be full because you are so driven by who you are. I have total faith in you. It's about changing the way we educate.
Well, going back to Dr. Carmel's comments, in all fairness, I've been a program chair, not criticizing SAGES, but this should have been a front-end session. It should have been no competing sessions, and it should not have been on a Saturday.
Before the next questions, I'd like to take the opportunity as one of the chairs here to present a medal. Every person on the Board of Governors was presented with a medal that they can give to someone who they think give extreme value added to this meeting in this, this forum here. And this is my medal as a Board of Governor. I'd like to give it to Dr. Carmel to exemplify what we at SAGES want to do. It's a small token, but this is important. I'm not the leader, but the leadership of this do feel that this is important, and we want to find out what we can do in order to improve the enthusiasm, to improve the response from SAGES to this healthcare reform. This name of this session is the SAGES Response to Healthcare Reform. And one of the goals that we have eventually is to develop what we can as a society do to respond, to prepare our members, to prepare our patients for this changing environment. It's something we look forward to. Dr. Carmel, thank you very much. Dr. Brunt.
Regardless of the attendance in this session, this has just been a tremendous forum, and I want to thank the speakers for coming here and being with us today. I'd like to ask a little bit about some of the excess in the healthcare system. It seems to me that one of the failures in our educational system is that we have not taught or emphasized to our trainees cost effectiveness in healthcare. We teach and train them to do whatever is necessary to take care of the patient, but we don't pay attention to the details of how many tests are ordered and how to deliver healthcare effectively. So I was wondering if you could comment a little bit on the role of our educational system in driving down the cost of healthcare.
Well, the curriculum there is being modified to address that. I mean, when you obviously go to a rotation there, there's a big emphasis not just on the management of how cost effective is this. So I think they're doing, I think we're way behind, but it's being done there. I think this is the first phase of it.
Yeah, I think we need to be more critical of what we're doing in an open forum. My classic example was I read a recent case report in the New England Journal of Medicine, and it was, you know, one of these typical case reports, a patient in an outlying community hospital who had a rectal cancer, and there was a complete workup done by all standards. The patient was transferred into one of the great Boston hospitals, who shall go nameless, who then repeated the complete workup and then added even more to the more than already complete workup, and had one of the most prolific, fantastic discussions in the case report. So I look at that and say, every surgeon out there is reading that article saying, I want to be like them and order all these tests too. And that is what's wasteful. When our own journals are out there teaching us to be this wonderful, yet we're not being resource attentive. We're over-radiating people like crazy. And part of this, though, comes down to defensive medicine, too. So if we don't fix the tort system, I can't ask any physician out there to practice anything less than defensive medicine because they put their professionalism at risk. Forget the dollars involved. So that has to be addressed.
Well, you're absolutely right. I teach medical students and residents every day, and there is this syndrome, which I call the elsewhere general syndrome, and you're right. All of that data from the outside hospital should be available to wherever the patient is transferred by pushing a button. It's all digital. It could be electronically transmitted in a fraction of a second. But if you say, let's get the data from elsewhere, they said, no, it's easier to repeat it here. So I went to the CEO, a woman who's now departed to a bigger job, a very effective woman, who, and I said, look, let's stop ordering these tests again. Let's make it a rule that a real effort has to be made to get the data from the outside hospital. And she said, Peter, frankly, we're very dependent on that income. How about them apples?
We have time for 2 more questions at the front mic and then the back mic.
Charlie Callery here in San Diego. Absolutely great panel this morning. There's such an emphasis on the doctors and the providers, but what I think we really need to focus on as well is patient accountability. I'm in weight management, my wife's in primary care, and we're struck every day how irresponsible our patients are in terms of doing their reading, doing their education, participating in their care, and in compliance later on. And I think that if we're going to bend the cost curve, we have to have a societal transformation where patients become responsible and accountable. Now, one of the auto insurers is putting black boxes in cars on teenagers, and I think you can get those for adults too in order to bend the cost curve on your health care insurance. And I think we need to at least schematically think of some way that we can hold patients accountable for their own behavior and pay more or have some other type of accountability when they abuse the system.
Well, very quickly, I agree with that. We have not done a good job of educating the patients. The patients who's not at the table currently today, I would have to say, are the patients.
Thank you for that comment. When I look at Don Berwick's influence on CMS, what Don brought to the table were three main points. One was healthy living, better health care, and more affordability. And that first one of healthy living, he has created a storm across the patient advocate world to figure out how do we address better healthy living across this country. And it is absolutely the number one key determinant of health is healthy living. It's not health care, it's not the cost, it's healthy living. So how do we do that? How do we green up cities so kids have a place to play and run around? How do we make good foods more affordable? How do we actually get into better exercise regimes throughout the entire population? That is a big investment by all the health plans, by CMS. It doesn't hit us, the white coats, but it is something out there for everyone to do. We can help promote it, but that is to the population in general.
Last question from the back mic.
Question comes in looking at the dichotomy that I see in healthcare, and we're talking about the physician side and training. My concern is the hospital. I see in practice, you find that it seems like as a physician, you lose some of the control. The hospital can then acquire, if you don't conform or join, potentially you could be replaced, and they could bring in their own organization and then direct referrals. So as you begin to talk about healthcare and who's here today and how this impacted, can you talk about the dichotomy and as I see it, the hospital has control over who they can bring on and potentially will direct patient flow?
Comments?
Well, you're absolutely right. Every PDAB hospital in northern New Jersey is forming an ACO because they know that talk will make physicians join the hospital as employees and they get more control. Hospitals are not innately evil. However, physicians who think that hospitals will always act to the physician's benefit are very mistaken. So we have to join with the hospitals. We have to be at the table. We have to determine the policies, not the hospital board, but the physicians. And that's why the AMA has always been insistent that ACOs must be physician-led. And it shouldn't be a physician who's a hospital employee.
One thought on this, and thank you very much for this question. The scariest part of this performance measurement world is that we take the focus off the patient. And the only people who really have that responsibility and training are the physicians and nurses and the clinical staff. If we become performance measure centric, that's all we're doing and we're actually trying to just pass the test and we miss the patient outcome, we really missed it. There's no way we can get performance measurement so right that we know we've got clinical difference, we've got meaningful difference for patients. The only way we can do that is from the delivery system, from the clinical side, having that voice in the boardroom where those decisions are made. So that's the biggest and scariest caution that everybody in the performance world has. Let's not have people studying to the test. Let's have people innovating to tell us when the test wasn't right, we need better questions because we need better outcomes. That only comes from the leadership of a physician.
Thank you. Concluding remarks from Dr. Lerner.
Gentlemen, it's been a pleasure to have you here. Your discussions were excellent. I think everybody who was here will walk out with a clearer understanding of what's happening and maybe with an idea of how to help influence the future of the healthcare reform as it presents to us. I'd like to thank all of you who have maintained the patience to stay here with us, and I must thank you also for the increase in numbers from the beginning of this session to the end. We look forward to repeating this function at SAGES each year at the annual meeting, and we certainly will be counseled to become as effective players as we can in this field of endeavor. Thank you very much.